So how does the new definition impact classification of the new PAH patients that are being included? In 2018 in Nice, France, we met and reviewed the clinical classifications of pulmonary hypertension. There weren't major changes. We still have 5 groups, with 1 being pulmonary arterial hypertension, 2 being left heart disease, 3 being lung disease, and 4 being pulmonary vascular obstruction, and 5 being a group of unclear mechanisms. But we simplified it a little bit and made it a little bit more user-friendly. So let's talk about some of these things in Group 1 disease. First, let's talk about these PAH patients who had a positive vasoreactivity test who remain in that group and are treated with calcium channel blockers. What defines that group? Those patients are either idiopathic, heritable, or drug and toxin-induced pulmonary hypertension when we cath them that have a PA pressure that is reduced by at least 10 millimeters of mercury and goes lower than 40 millimeters of mercury without a decreased cardiac output. And they do respond to calcium channel blockers with functional class 1 or 2 symptoms that is sustained for more than 1 year on calcium channel blockers alone. So those are a special group of patients and are clearly listed in the Group 1 category of PAH in the new definition of pulmonary hypertension. We were able to drill down more on the drug and toxin patients. We now have clear, definite associations of PAH with our standard causes like amenorrhea and fenfluramine, but also methamphetamines have been included as a definite cause. And we have our possibles like cocaine and amphetamines, which should raise our suspicion, but not clearly proven to be associated. This helps physicians to target patients that could be at higher risk and evaluate them at greater depth. Now, we also have included in multiple years the pulmonary venous, the PVOD patients, and the pulmonary capillary involved patients, or the PCH patients. We have a greater understanding of this subgroup of the PAH patients now than we did in the past because we have been able to study them further. We now know that they have a genetic basis for many of those individuals. We know the hemodynamic profile and the pulmonary function profile. These are individuals with low DLCOs, greater than you would expect, and severe hypoxemia. On CT of the chest, they look like they have pulmonary edema with septal lines, ground glass opacities, and mediastinal lymphadenopathy. And when you treat them, they can develop pulmonary edema. We also have learned over time that this condition may be associated with occupational exposures to organic solvents. Our Group 2, 3, and 4 have relatively been stable without much change. Our Group 5 remains a nebulous group we don't know how to manage well. And in that group are our chronic hemolytic anemia patients, myeloproliferative disorder patients, and systemic disorders like Langerhans cell histiocytosis, Gaucher's, and glycogen storage diseases. We need to study these groups to better understand how to manage them, and we don't have any FDA-approved therapies for these individuals.